Today we're going to be talking about thalassemia. And some people will wonder, why are we talking about thalassemia on the World Sickle Cell Day? We'll answer that. Good morning, Professor Akanmu and Dr. Akinsete. It's a pleasure to have both of you with us on the program. Thank you for coming.
Good morning.
You're welcome.
So if I can just start off with the people who are wondering, why are we not talking about sickle cell today? And the real reason is that, for me, thalassemia is a condition that nobody knows about. If you ask 100 people on the streets of Lagos, what is thalassemia? Nobody will know. And yet, some of them will have thalassemia. So it's a very important condition. So I don't know if I should start off with Prof, just to say, what is thalassemia and what's its relationship? Is there any relationship to sickle cell disease?
Mm-hmm. And then Professor Akanmu is, yes, indeed, best position to set the stage on this. Professor Akanmu.
Thalassemia is a blood disorder that as sickle cell anemia. This condition, unfortunately, can coexist with sickle cell anemia, and if we make sickle cell anemia to be less problematic, or make sickle cell anemia to be extremely much more problematic.
I'm sorry, Prof, I'm sorry. When you just report.
Down again.
Go, sir, go.
Thalassemia is a disease of the blood where amount of hemoglobin that is produced is extremely low, just the way the amount of hemoglobin that is also present in people with sickle cell anemia is extremely low. Unfortunately, they can coexist together, but the cause of the two disorders are completely different. As for the so-called sickle cell disease, the blood is being formed, but the blood is being destroyed at a very, very rapid rate. So the blood does not stay long in circulation and makes the individual to become anemic. But as for thalassemia, the individual is incapable of synthesizing the hemoglobin. So the amount of hemoglobin that this individual has is genetically low. The blood may also be destroyed at when you have thalassemia, but the major problem with thalassemia is that you have a gene that has the problem of not being able to be expressed the way it's supposed to be expressed. And we say there are two major types of thalassemia, which agrees with the two major types of proteins that makes up the hemoglobin molecule. Hemoglobin molecule, we say, is made up of what we call alpha chain and beta chain. There is a gene that codes for the synthesis of alpha chain. There is a gene that codes for the synthesis of the beta chain. If you have the alpha chain gene that is not being well expressed, the amount of alpha chain gene will be very low, and you will now have excess of the beta chain gene. That excess of the beta chain gene is what causes the disease. But we will say you have alpha thalassemia, the gene that are not being able to produce. If it's a situation where the beta chain gene is not being expressed, so the amount of beta chain that molecule that you're going to have will be very low, and then you have excess amount of alpha chain gene, and that excess of alpha chain will give what we call the disease. But we will say you have beta thalassemia. The gene that you're not able to express is what we use to label the type of thalassemia that you have. Many people, if you ask me, what is the proportion of people that have beta thalassemia or alpha thalassemia in the general population is as high as 40%. The study that was done by many people at University College Hospital from 1973 till date, that prevalence has not changed. And the same prevalence has been observed even here in Lagos among our students who have been looking at what's the proportion of individuals that we have around that have either alpha or beta chain gene. In fact, a number of our students also look at the prevalence of either alpha chain or beta chain in patients that have sickle cell anemia. And the prevalence is also not different among patients that have sickle cell anemia. And this is why I say sometimes the thalassemia as a blood disorder do coexist with sickle cell anemia. And when they do so, it can make the expression or the clinical expression of the sickle cell anemia to be a little bit better, not too, that the individual does not come to the clinic like every, and we wonder, does this individual have a coexist serious it's like in and out of the hospital and the individual becomes a problem when an individual comes and has a thalassemic problem, and we will say, this individual is coming from an is hemoglobin AA, and the mother is hemoglobin AS, and now you are having a child that's hemoglobin SS, that can actually create a problem. You would think it is impossible to have an SS child from a mating of apparently an mother problem, because what normally happens in such a situation is the fact of the one of the parents of let me explain it. Or the child receive beta-thalassemia gene from one of the parents and receive the S gene from the other parent. The hemoglobin type of the child will appear as if is SS. What is happening is that receive from one of the is not being from the other parent, and that this individual has inherited SS. This is what we call beta naught S, and is the individual, and the clinical features is typically sickle cell anemia, and it's a problem in fact when we do not understand if it's actually inherit thalassemia, don't have severe disease the way patients with sickle cell anemia tend to have disease. We also have the grades of thalassemia, but majority that will have, because we see about 40% of the population actually have thalassemia gene, but it makes them to have low level hemoglobin. You will see individuals having hemoglobin 10 grams per deciliter, 9.5 grams per deciliter. You say, this individual is anemic. You will now be investigating for all causes of anemia and not going to find an answer. What we do not investigate for is the thalassemia gene. And only if we have to go for what we call hemoglobin variant analysis, it will give an indication that something is going on here. That is there. It's not an anemia, is this individual's constitution. It's just a thalassemic gene. Let me stop here and then take more questions.
Well, thank you very much.
Wow, we are back.
It's interesting you should say that, Prof, because I actually had a very close friend of mine who was actually AS. She was always diagnosed AS of sickle cell. And she was with me. She actually came to medical school. We were together in Unilag. We were together in Medilag. And then she died at a very, very early age of complications typical of sickle cell disease. And yet, all through, she had tests in England, tests in, everywhere. They had always said it was AS, and they couldn't understand why. Could she have been a case of thalassemia and sickle cell disease?
No, it's simply a case of what I will call SA and not AS. Thalassemia aging, you allow S gene to be produced in large quantity. A normal AS person has a normal A gene, a beta A gene, and you produce the beta A gene usually in large quantity. So if somebody is AS, you do differential concentration of the A hemoglobin and the S hemoglobin. The A hemoglobin will be about 70%, and the S hemoglobin will be about 30% to make up the 100% hemoglobin that you have. But in an individual that has thalassemic A gene, the A hemoglobin is not being produced. So in a large quantity, and then you will now have differential expression or increased expression of the S gene. It will not appear as this individual is hemoglobin SS. But this one that I talk about, you still have little amount of hemoglobin within is AS. It is when you do hemoglobin variant analysis, that is, you quantify the amount of different type of hemoglobin that individual has is very, very small. That aging is not being produced in a normal quantity AS. That individual, ideally, we call that individual SA. People ask, what is SA? Well, you have SA when you have.
How is SS? How is when I'm AA and my wife is AS, or when I'm AS, my wife said she's AA, and there's a lot of, back and forth. The counselors come on board. There's a lot of talking, counseling goes on, and then testing and retesting, because we have, various levels of validation before tests are given out. I think what Professor Akanmu has said is correct. And then our scientists come out and say, oh, this is thalassemia. And then they sit down and explain to the family that you didn't really, you're not really you're not A. That's what we do. Because this is very clearly that people don't know what thalassemia is.
Yeah.
Italian is not Nigerian, it's not English. It's not something we are used to hearing. Thalassemia refers to the sea, because initially it was thought to be something we found associated with the Mediterranean Sea, because that was where the disease was found. Of course, it's found in areas beyond the Mediterranean. It's found in Africa. It's found in Asian subcontinent and all of that, okay? But that is it. So we now take them on as ambassadors, these couples that have been so affected. There are not many, but we do have a register. I don't have the numbers. We have a register, okay? But I will speak from the point of view of a public health person, rather than as a clinician, that in population health, we don't talk thalassemia at all. You actually said it that we have a World Thalassemia Day. We don't. We don't have a World Thalassemia Day because we see it as a public health priority. It's not, and this is not yet a public health priority. Having said that, thank you and kudos to you, Pamela, and your team for bringing this to the fore, for saying, let's discuss. Because the more we talk about it, the more we discuss it, the more it reverberates and people begin to say, aha, there's need to, bring this to the front burner. And then at the end of the day, the UN begins to hear. Okay, it's the United Nations that determines all of this. But come to think of it, when did sickle cell have a World Sickle Cell Day? Not so long ago. I was even privileged and blessed to be in New York headquarters at the UN headquarters at the time when it happened. But it took a lot of lobbying, a lot of fighting and the writing and negotiating before it was brought to the front burner and discussed and agreed in 2000. And a resolution was passed in 2008, and in 2009 we celebrated the very first World Sickle Cell Day. So a lot of all these things requires a lot of negotiation. And I talk to medical students, that doctors, as we are, we need to learn this art. And that's the art of life, is living. You have to learn to negotiate. You have to learn to lobby. Otherwise, your agenda will not be driven. So that's World Sickle Cell.
You are very correct.
The Global Association, GANSID, Global Action Network for Sickle Cell and Other Inherited Blood Disease. Because these are diseases that are not cancers, not the leukemias and all that, inherited blood disorders and blood diseases. Okay, now we are already making the push for all these conditions, that is hemophilia included, thalassemia included, and there are others, Everybody thinks, oh, they're not important, they're not common. Why talk about them? But you see, if you talk about them, for those that it affects, it's so important. It's so important. So soon we are going to have such a day, a World Inherited Blood Disorders Day. So that negotiation is going on. We're doing a lot of writing, a lot of negotiation as we speak, a lot of lobbying.
Fantastic.
So in Nigeria, that's something I must put down here. We don't have to wait for United Nations to talk about it on a global level. Our own legislators here in Nigeria, even locally, more locally, state by state. But let's still start with our National Assembly. They're there for us to work with. But again, our democracy is still young. We don't know that, but it's true. We're still very young, but that's the way it works. For our democracy to really work, we have to see ourselves indeed as part of government. If we're practicing a true democracy, it's a government of you and you and you and myself and them. So we can put up a bill, sponsor a bill. This is what we want. Let's push for it. A World Day that looks at all aspects of these conditions that are not cancers.
Thalassemia. Yes.
Thalassemia. Yes, I think I'll stop there for now.
We need to look at that. And what I wanted to actually bring out was, it's very important. Thank you. It's very important to look at the actual condition thalassemia, because I remember when I was the MD of PACCARE, when we started PACCARE, this young lady came up to me at a function actually, and she came to me to say thank you. I want to say a very big thank you, because I finally know what's wrong with me. All my life, she said, I've always felt ill. And I tell people, I'm ill, and I have symptoms. And then they check and they say, no, you are AA. And I know there's something wrong. I always knew there was something wrong with me, until one doctor sent me here to check for this, and they've told me I have thalassemia. And now at least I know. Because some people are going around with that feeling of being unwell. And yet when they check them, they see AA, and Prof can explain it further to us, but the symptoms are there. They are mild versions of sickle cell disease, but they are feeling unwell. We don't have, unfortunately, this is actually a big topic. We actually have to find more time to talk about it. We only have the end of the show. So I just like Prof to say something, and you to also say something, just a few last words for our listeners before we sign off. Prof.
Yes, that lady can be symptomatic if she's hemolyzing the way patient with sickle cell anemia will hemolyze. It means that she has a more severe thalassemic disease. Like I told you, there are two hemoglobin molecules, the alpha chain and the beta chain. So if it happens to have the beta thalassemia, it means that you have excess of alpha chain. So ideally, you should have 2 alpha chain and 2 beta chain in equal proportion. But at this time, you now have some alpha chain with some beta chains that form the normal hemoglobin. The excess of the alpha chain that you have is a problem, because those alpha chain will now be 4 molecules of it will now be joining together to form what they call alpha tetramer, and that actually causes destruction of the red cell. And of course, if an individual also has what you call the type of beta thalassemia, and you have excess of alpha chain, those alpha chain, they collect oxygen and retain oxygen, and they don't deliver oxygen to the tissue. The normal hemoglobin, that is 2 alpha chain, 2 beta chain, collect oxygen and deliver oxygen to the tissue. When you have 4 alpha chains, it collects oxygen. We say it has high oxygen affinity. Even if hemoglobin appears to be near 10 grams per deciliter, 9.5 grams per deciliter, hemoglobin and oxygen is not being delivered to your tissue. You will have severe unwellness compared with the level of hemoglobin that you have when you have excess of alpha chain that are forming what they call tetramer. And if it is the beta thalassemia, and you now, if it's the alpha thalassemia, that you now have excess of the beta chain, that is also a problem, because the beta chain gets deposited on the membrane of the red cell internally and destroy the red cell. The way sickle cell anemia gets easily destroyed, you'll be fighting. So this is the reason why in some form of thalassemia, you'll be having features that is looking like that of sickle cell anemia. So your patient can actually be very unwell. But the majority of patients with alpha thalassemia have mild to moderate thalassemia, and the movement around 10 grams per deciliter. They are able to cope with normal routines of life without much problem, until the type of problem that Dr. Akinsete was talking about. My wife said she's AA, and if this one is AS, how come we are having SS as a child? This is the reason why some of these actually come up. And sometimes you may not even know until you have what we call oxygen challenge. Oxygen challenge comes in situations when you are pregnant, you need oxygen to be delivered to the tissue. You are now suffering from anemia of pregnancy, and of course, the thalassemic gene is there. You might actually have more severe anemia of pregnancy compared with an individual who didn't have. For the first time, the features of your thalassemic inheritance will be coming up at such time. Situations of increased oxygen demand. And the typical example is pregnancy.
Thank you very much. We've actually run out of time, but I just want to ask Dr. Akinsete, should we or should we not ask people to be testing for thalassemia in Nigeria today as part of the screening process?
Screening for what? Because again, if you ask me personally,
screening for marriage, before marriage.
Yes, even that screening for marriage it's something that people have determined to be discriminatory and stigmatizing. So it's good to have the knowledge, rather than to say screen. That's my own personal opinion. Having said that, when eventually I know there will be a law, because right now there's a bill on the floor of the House talking about screening for sickle cell, and I believe that it was a question of time before thalassemia comes on board as well. But to what extent is thalassemia that common? Is it that common? One, because you're going to talk about population health. Is it that common? If it's not that common, does it make that much sense to do so? So I would say no. My simple answer is no. For the purpose, and the simple reason that I think is discriminatory and stigmatizing. Thank you too.
Thank you very much. I appreciate this conversation. Thank you very much, both.
Thank you for watching. Please like, share, and subscribe for new video updates.